to get into schema go. But by doing this, I think we want to cultivate a culture of research and publication within all the staff here. So that's a whole goal. It's not about, they have the capability and they know the job, how to do it, but that's not known to many people. But make that training and share your technique or knowledge to others to succeed also. So anyway, thank you.
Okay.
Okay. Thank you. So are we ready?
Yes.
Okay. So good morning, everyone. I would like to have the privilege of hosting Professor Judith Kashmir from ASU here in our IHM campus today. And she graciously agreed to conduct a session on global solutions in nursing studies. And that is also mainly focusing on academic partnership practices. So that's basically we're going to work between IHM and ASU. And this is a real partnership. It is not a partnership like a lot of MOU signed by many institutions. We are really integrated. We want to take the best advantage of it. We can get the most learning from ASU's culture of continuous innovation. And I think we are also an innovative institution. One of our key values is innovation. So I can list down so many innovations we've done in the last 20 years. And we want to continue to grow that one to a global standard. So I don't want to say more, but I think this is an opportunity for Professor Kashmir to give us some highlights. Thank you.
Thank you. Thank you. I'm delighted to be here. Thank you. I'm very excited to hear about your work in public health. As I was mentioning to your colleagues yesterday, ASU is launching a School of Public Health Technology, be up and running by fall of 25 with students. So I think there's lots of opportunity for that mill of publications and research, so just really terrific. So I'm delighted to be here for a very specific reason. So as a Dean of the College of Nursing and Health Innovation at Arizona State University, I have had opportunities from many international partners. We've had fits and starts in many different countries, and although intentions were good, the follow-through never was successful. The fact that your university, your school, your programs, and Sintana and Ramsey Health have come together is, for me, the linchpin that can make this work. And because of that, I am absolutely sure that this partnership is just at its infancy and will continue to grow to the advantage of you, to the advantage of Ramsey Health, to the advantage of Arizona State University, and more importantly, to the people that we serve. So because of that, I thought I would start with talking about how partnerships are really looking at the nurse of the 21st century. And this is really the workforce of the future. And I want to talk about the nursing workforce of the future. I'm a nurse. I'm a dean of a college for nursing and health innovation. I know you have other health professions, and we, of course, see that healthcare is a team sport. One of the values in my university, in my college, is interprofessionalism. So I take the nursing piece very seriously, knowing that that's a key part of the professional team. But in the future, and today, actually, yes, yesterday, the nursing workforce has to be tech savvy. They have to be data driven, and they have to be able to integrate advanced technology. Data literacy isn't something that is for other people. It is for the provider today. And if it's not for the provider, trust me, it already is for your patients and your consumers. So important is to know that from the very beginning, this is part of the responsibility of the nurse of this century. Many places, we used to talk about electronic health records as somehow just a technological representation of handwritten notes. That can no longer be the case. You, as a provider, cannot spend hours reading all the notes from everybody else by the time you get to enter your few things. We did an interesting audit of nurses' notes. Nurses' notes tell more about the nurse provider than about the patient. The nurse is more likely to say the same things regardless of the patient than patients about, you could tell who the nurse is, but it was hard to tell who the patient was. So I think that's a perfect example of how taking what you learned in paper translating a technology is not what we need for this century. Another feature of the nurse of the future is that they have to be culturally competent. I've been in Melbourne 2 days now, and I can see what a wonderfully dynamic, culturally rich town this is, and the country. And so perhaps it's something that rolls off your tongue, and you know how important cultural competence is. But we take great effort to make sure that our students are both representative of the populations that they serve, and that when they are working with different populations, they work to understand those populations. And it's not just understanding that they may be different, but really understanding that the care that's provided is acceptable or not in many ways. It's also important for us to realize that the global communities, this is no longer just a pipe dream that we are a global world. I think we learned that during COVID more than anything, that what was in the past borders, that those no longer existed until we closed them. So I think it's very important for us to think about, as we look at the nurse of the future, he or she must be able to move from one global community to another. The nursing workforce of the future is specialized and highly educated. The track that you are on here to move career opportunities, to increase the educational opportunities for the work-ready nurse is exactly the kind of approach we need to have. We need to get people out, but we also need to have constant lifelong learning. Would you be scared if the nurse taking care of you hasn't learned something for 12 years? I'd be scared. Would you be upset if the physician doing surgery on you has not upgraded for the last 15? So I think it's very important that it's not only the graduation, the credential that you earn, but the fact that built into both your education, the educational expectation, but your employment expectation provides ongoing opportunities for growth, learning, and credentialing. People start and stop schools at different times. We need to be accessible to the high school graduate, to the 40-year-old, to the 60-year-old. So they have a way in without being treated like they were when they were 18 or even 25 or 30. The same cultural competence that we need to have for our patients and their families and our communities, we have to have for our learners, for the students coming to our programs. We are not the same in terms of our educational needs. If you are a first-generation college student, the kinds of support you're going to need are going to be different than the kinds of supports that somebody who has really been on track for college, university from the very beginning. As I mentioned already, the nurse of the future has to be collaborative and team-oriented. We are working very hard in the United States to really transform primary care through the use of advanced practice nurses. We have a large commitment to family nurse practitioners, adult nurse practitioners, pediatric nurse practitioners who actually are running the clinics, who are running the opportunities to see a provider, a GP, on a regular basis. But even more importantly, chronic disease management being driven by the nurse. You do not need a nurse practitioner to do chronic disease management, diabetes, asthma, hypertension. And the idea that you are educated enough in terms of your scope of practice that you can be the provider for the person who has hypertension. You as the nurse can see the patient on a regular basis. That person does not have to go back to the physician or the nurse practitioner. The nurse can manage the chronic disease and be the liaison to the provider. That gives us so much more flexibility to go into the home, to go into a telehealth experience than always depending back to the primary care provider. And that's why we need this team approach and a better educated nurse. We need the nurse to be at the policy level. I have heard about policy changes here in Australia about foreign international students and access to education. We need people that are looking to the overall health of our communities to have a say in policy. So in an educational program, you need to have a big dose of policy and the role of the healthcare provider in policy making. We can't give away policy making to legislators or politicians, just like as providers, we can't give away informatics to computer scientists. We need them, but we need to be part of the conversation. I don't know if any of you guys are TikTok or Instagram or those kind of things. Surely you do, right? Are you just like a quiet group here? I'm getting that. Well, a big, big place of influence for healthcare policy, belief, is on social media. Whether you like that or not, it's true. I read an interesting study recently, about a year ago, that the single most frequented place for someone to learn about drug side effects is TikTok. They go to TikTok. And why? Because they don't have to read the entire story about the side effects of the hypertensive medication. You know, Manuel says, I take a medication, I take this much of it, and this is what it does to me. So the influencer isn't teaching you about what you need to know. The influencer is sharing what I know. We need to take heart in that. We need to make sure that if you're going to be an influencer in policy and healthcare, that you understand the power of what your constituents need to hear. We need to really think about the fact that our care needs to be patient-centered, holistic. I've been a nurse forever, and we've been talking about patient-centered and holistic care forever. Obviously, we have not gotten it right, or wouldn't keep being the item, but we have to really look at what is it that you need when you go to a provider. First of all, you want it fast, right? You don't want to wait. You want it to take into consideration that you could be a little upset because you just flunked an exam. You want to have people to take into consideration that getting to this appointment was hard, and that we are not only treating the headache you have now, but preventing it in the future. So it's very important for us to really look at how are we looking at both prevention as well as treatment. In the nursing education accreditation sphere in the US right now, we have adopted the language of 4 spheres of care. And these are the 4 spheres of care: disease prevention, promotion, chronic disease management, as I was mentioning, the role of the nurse, not necessarily the nurse practitioner or the physician, regenerative and restorative care. How this is differentiated is if you break a hip, it's not just getting better after the broken hip. It's being able to go back and do that marathon, being able to play basketball again. It's not just the recovery, it is regenerative, so you have a lifestyle again. And if you don't have a nurse that cares about that, then we've really missed the boat. And then last, of course, we really need to pay attention to hospice, palliative, and supportive care. End of life is not necessarily the last few weeks, it's the whole supportive care. And how is it that the nurse is prepared to provide the care, but who else are we taking care of? That whole family. If you've ever had a family member needing supportive care, you know that the single thing that can make a difference is that nurse helping to take care of you. I was just seeing on TikTok, I think about a nurse that was taking care of a child in a NICU. And the thing was what the nurse did when I wasn't looking. And it was one day the nurse took the footprints and the handprints of the baby and put a sign on the thing. This is what I look like at 2 weeks. One day it was a picture, and remember me on this day. And there are all these little things. Of all the things that this mom was talking about made a difference in the care of her baby who was having supportive care for 100 days, wasn't the tubes, wasn't the medication, wasn't all the things, was how the nurse took care to know that she needed that support. Flexible and adaptive to changing work environments. Our colleagues from Ramsey Health speaks quite eloquently about this, that the way that people want to work today is different than it used to be. We always joke with our graduates, you know, they graduate and they get offered a job and they say, I have to go to work 5 days. It's like every day I've got to go to work. That this is really a problem, that the notion that, I'll give you an example. During COVID in the United States, We saw a huge increase of traveling nurses, nurses that could go anywhere, get a lot of money. They quit their jobs and were shipped wherever. And one thing they liked about it was not the money was good, but it was also they could say, I only want to work February and I want to do it in Southern California. Or I only want to do June in Maine. So they were choosing where, when, and the shifts they wanted. In the United States, most emergency departments are run by physician groups. And those physician groups are not employees of the hospital. They are employees of a group. And then they sign up with a group that I want to work Thursdays through Sundays. We need to be responsive to nurses having that same kind of control over their employment, when they work, and how they work. And we also need to really see that much of healthcare is in non-traditional settings. It's not going to be the acute care setting. It's not going to be just in the hospital. We have many of our large systems in the United States doing what we're calling hospital at home. And if you live within an X radius of the facility, Mayo Clinic in Phoenix, really fabulous hospital. If you live within 20 miles, you can get admitted to the hospital. If you have a certain diagnosis and you have a family caregiver, you get admitted and you go home, which is a much safer place, much less possibility of getting an infection, and you are cared for by a nurse who is working through your family caregiver in your home and constantly monitoring you. And we're going to see more and more of that. We got to take care of the focusing on well-being. In Phoenix, where I am, during COVID, we sent our students home in March for a few months, and then we brought them back. Nurses were working triple shifts. They were taking care of very sick patients. They were then having to come home and take care of their own families. They didn't, and we didn't know a lot of stuff. So everybody really worked hard, and now there's a huge sense of, we have a lot of people feeling bummed and burned out and not happy and feeling unloved and unappreciated. The Surgeon General of the United States has coined the phrase that belonging, or lack thereof, is the public health menace. That is the biggest problem, that people don't have the sense of belonging. They don't feel connected. And what are we going to do about that? I also happen to have the role at ASU as a chief wellness officer. And the chief wellness officer's role is big. And what's really important is, at a university like ours, we have so many programs. We have yoga and mindfulness and intramural basketball and cooking classes and health checks. But until wellness is a value, it doesn't make any difference. And what do I mean by a value? A value that you care when you hire people that it's going to cause a strain in their family. When their dog gets sick, that's going to be something that they can talk about, that they have a chance to share what's worrying them, and that instead of telling them what wellness practices they should be doing, you start with, what is your wellness practice? Everybody has wellness practices. It may be you wear sunscreen, but that's a wellness practice, and we should identify it and celebrate it. Your wellness practice, I only drink light beer. That's a wellness practice. Whatever it is, we need to start there and make the value of wellness our priority, because nurses and health professionals are getting tired, and they just buying them pizza doesn't work. We have to be prepared for public health emergencies. We need to not think about this as something that is never going to happen again. It's happened. Things like this happen all the time. If it didn't happen in our neighborhood, we weren't aware of it. We need to be aware. We need to build this into our curricula, and we need to know that the patient is just a representation of the community. So that's nursing workforce of the future. The last one, because I'm going to now talk about technology and partnerships, needs to be ethically grounded in AI and technological integration. This is all those things, but today, what we talk about and what you were talking about is technology and AI. And we need to be aware of the ethical concerns. You have an expert here to talk about the technology and the impact on nursing from the ethical perspective. This whole idea that we need to be aware of everything from privacy to bias. I was working with a firm that we are working with in AI, and this was a year ago. And we asked in the AI, what are the symptoms of pain? How is pain experienced differently between men and women? You cannot believe what a biased response we got. Women have lower pain threshold than men. That they said that. That's what it said. And our colleague from the company said, I think we'll have to check on that one. So let me talk a little bit about technology, nursing education, and nursing care. So let's talk about AI in nursing education. This is, I know, something that you here are very involved in, and it is something that we at ASU are really marching down this path. 2 years ago, I don't even know if I was sure what AI really was. I know it was around, but did I know about it? Probably not. I mean, I maybe did, but I didn't know. So the whole idea that it has provided us now with the opportunity for personalized learning during COVID, we sent our students home and we started doing virtual simulations. And now that they're AI mediated, they're amazing. The automated gradebook and giving feedback. The fact that faculty can now use automated feedback for students. Talk about saving time so you can do something fun. This has been a great opportunity for us. And the fact that we can now use data-driven insights for curriculum development. We are in the process at my university of revising our nursing undergraduate curriculum because of the new essentials document put out by the American Association of Colleges of Nursing. It is a competency-based approach, and many of our faculty weren't exactly sure what competency-based education was. So we've been able to actually train up faculty through AI to understand better both what is competency-based education and, even more importantly, how do you assess it? And now we're looking at how does AI help with assessment of competency. AI improved clinical decision making. So it has already changed the way that we make some decisions in clinical practice. Now, how that's built into your practice varies by where you are, what you're doing, but we already know that many of the projections of next steps are being generated by AI and machine learning. I recently saw a chatbot of Nurse Clara that was probably one of the most impressive chatbots I'd ever seen in interfacing with a patient about his medication, who also happened to be depressed and upset. And this chatbot was able to monitor her tone, the way she talked to this guy, that even though you knew it was a chatbot, you saw a little, figure, by the end of about a 15-minute conversation, I was convinced it was a real person. It seemed like a real person. And I believe that when I was talking about chronic disease management, we're going to be using more and more and more of nurse-driven bots that are going to help immediate access. Immediate access. That's what we want. We took an Uber here. We waited, 3 minutes? If it had been 10, I would have been calling Lyft. I'm not waiting 10 minutes for an Uber. Why should you wait 10 minutes to talk to a nurse or a physician? And then the whole symptom checkers and triage tools. This is going to be something that, especially in hospital home opportunities, that we have ways that we can monitor. I have a colleague who's doing some work on remote sensing in shoes for people who have Parkinson's and gait problems, and it helps drive that. And we also have some interesting monitoring in our sleep lab that is really helping trigger people that we would not have known until after the fact for interventions. When we looked at the data later, now we can have real-time feedback. Patient monitoring, care delivery. There are lots of wearables and robotic assistants. If we don't think they're already being used, you're missing the boat. People are out there buying this right now. They're taking off-the-shelf things and they're doing it. They're monitoring themselves. They are investing in themselves through whatever they can find. How many people have Fitbits? How many people are already monitoring? I use Strava. I mean, I look at what the feedback is and change my behavior. That's the key. People are changing their behavior based on feedback from remote. You can now get your blood glucose. You can get everything off your Apple Watch. And then it changes your behavior. So if you as a provider are not doing that, you better be worried because your patients already are. workflow. I have been in academic nursing forever, and I have never been to an emergency department that is well organized. And I have never seen a hospital know what to do when they have too many admissions at the same time. And I have never understood how you could actually have a code for the room is the hallway. Trust me, I know lots of US hospitals that the room number is the hallway in the emergency department. Now, one of the biggest reasons isn't the number of emergencies that come in. We know how many emergencies. It's getting rid of the patient, that's not a good thing, discharging the patients who are already on the unit because they are separate from these people in the emergency department. They are not communicating. They do not know what the patient's not, and the mother didn't come in time, and these are good reasons, but they are not what we need for the 21st century. I am hopeful that with technology and our providers appreciating the power of technology, we can start actually looking at workflow and the organization of our workflow. Those of you that are familiar, there are some major things that we worry about in hospitals that may seem unrelated, but one is falls. Falls are a huge, big deal. And there's so many protocols on falls, fall prevention. And the fact of the matter is patients, the moment they get those bans that say you're a fall risk, hate it. They don't want to be a fall risk. So they start doing stupid things to demonstrate they're not fall risks. So we need, just that alone, we need to use understanding to change those behaviors. So changing the word from fall to balance can make a huge difference. And that's the kind of today knowledge we need to be able to make a difference in something that may seem like not a big deal, huge deal, falls. Big deal. Support for evidence-based practice. As I said, you don't want to have a physician or a nurse or a physical therapist taking care, or a nutritionist taking care of, what do we know about nutrition's changed over time, if you don't have most up-to-date. And how do we deliver that in digestible pieces of knowledge? Not the entire, yes, of course, at some point it was great to use the entire article, the entire study, understand it fully, appreciate it. But to have secure and trusted information that you can use today. I'm sure you all are aware of how long it takes from research to change the bedside. Years. We need to use the power of technology and AI to use it today. Now, today, with the idea that, of course, it's been vetted and it's been tried out. And, it can't be, oh, I saw this neat article, I'm going to do this. Although during COVID, that's what we did. Nurses found out that if you put the patient on his prone instead of supine, and they're having respiratory problems, they do better. That was not a big study. That was an observation of nurse innovation. Or as I said yesterday, we used to call it nurse workarounds. Now we call it nurse innovation. And we need to be able to harness that in real time, in short bursts. The other thing we learned during COVID is how the lack of health literacy can devastate communities. How do we get the information to the family, to the community, to the patient? Those of you that have been in healthcare for years know that we have some algorithms. It has to be at the 5th grade level. We try to make it culturally competent. We come up with these handouts. We give these handouts. How many of those handouts are ever used? How many of those never make it home? How many of them say, I don't really know what that means, and have no place to go? This is what AI can help us with. This can help us make it age-appropriate, culturally appropriate, and timely. Timely is the key here. I don't really care when I'm being discharged, but when I'm home and I'm supposed to take that medication, I'm not exactly sure how to do it, that's when I need the information. Those of you that have parents, I can remember when I had a young baby, like 3 months old, and you get a fever in the middle of the night, you know what to do. Fortunately, I had a friend who was a nurse who I could call. I'm a nurse, but I had to call a nurse in the middle of the night. Her fever's 103, what do I do? Because I needed to hear that from somebody else. So we have such power here that we need to be using in our ongoing health literacy and our education to our patients. And as I said, it's our chance to really help with well-being. Writing notes, taking the notes, the whole opportunity that could be helped by AI can make all the difference in the world. It could make your going to work something that you don't dread because you're spending a whole 45 minutes at end of shift filling in all the things that you didn't fill in during the day. This could be a game changer for more time at the bedside. We need to really be doubling down on use of this, testing this out, finding out how this works so we can implement this. I also see this as a huge part of nursing education. So those of you that are nurse educators or healthcare educators know that learning how to think like a provider, learning how to think like a nurse is much harder than learning how to do the skills. You know, anybody can learn how to do an IV and do a, sterile field and change a dressing. It takes clinical judgment to know when to do it, why to do it, what's the impact of what it looks like, the judgment. And that judgment piece is learning to think like a nurse. How do you learn to think like a nurse? Well, one of the things that a virtual assistant can help do is talk the student through in AI. This is what I'm doing, why I'm doing it. I always tell my faculty that you should never waste time with students delivering content. They should always have the content before they get to your class. And in class, you should have the opportunity to let them reason through with you. So if someone asks you a question, Professor Karshmer, what about this? You don't say, go look that up. You say, let's reason it through. Let them see your thinking. Let them see your decision making. It should be the gift that you're giving them. It's not the answer, it's that process. And I am thrilled that these virtual assistants should be able to help us implement that. And I think that another is just increasing access to opportunities for us to prepare at higher levels. We want to increase access to nursing, but we want to increase access to the nurse. And let me give you an example of a Navi Nurses, which is a startup that was started by a nurse at my university who was a PhD student. And she was teaching, we have a course called Introduction to Nursing, funny thing about that. And it's really tries to say to the students, these are freshmen, first-year students. They know nothing about healthcare. These are 5 big health problems. Over the course of this semester, come up with a solution or an innovation. And then they spend the semester figuring out. We have faculty come in and talk about issues. I came in and talked about back pain, and issues with back pain, and how it impact on the economy and loss of work and pain and blah blah. And then they come up with solutions, and some of them are unbelievably crazy, and some of them are like you think they're going to be billionaires by the time they're 20. But she was a TA for this course. And she said, well, I've got a couple of ideas. And so she went to the professor who helps manage the innovation piece. And he worked with her. And her idea is instantaneous nurse when you need it. It's sort of like Uber for healthcare. And she started a company. She has over 200 employees now, where you call her and you can say, my husband just got discharged from the hospital with a broken hip. I need to get him settled. Come in for an hour, 2 hours, whatever. I need to have someone come in every day. My son was just discharged from the hospital. I need help in administering his IV. My mother was visiting from Florida. I need to get her back to Florida safely and go. So whatever you need, you get a nurse. Navi Nurse, she deploys these nurses. They work when they want, when they have the expertise is cataloged. She initially won a $50,000 J&J pitch. She then did another pitch. It got $100,000. And then she was adopted by the Mayo ASU MedTech Accelerator for a years-long mentorship. And she is a mover and shaker now in an approach that provides nurses when you need them on call in the home, totally driven by the needs of the patient. Now, none of this has been picked up by insurance yet, so it's all out of pocket. She's doing fine, however, because they pay for what they need when they want it. So another one, I just want to give you some examples, is redesigning the workplace. So we had a pitch, we have a summer internship. These are nursing, engineering, I think we had a public health students, I think we had 12 of them. And they were given a task to, an issue to do something about. And the issue was one of our partner hospitals, they did some focus groups with the nurses about what are some of the biggest things that cause problem with your nursing care. And they were complaining about the computers on wheels. The wheels, they're called, I think they're something on wheels. Well, whatever. And they, the rooms, they're big. They've had them for like 15 years, so they're big, and they take too much room, and you can't get them under the bed. So they leave them out in the hallway. They go in and they do the care, and then they go back and have to do the charting and the thing. But that was the whole point, was to have it with you. So they went in, and these students, these are all undergraduate students, met with them, and they redesigned the computer on wheels. The Workplace on wheels, that's what it is, wow. They redesigned it based on a whole bunch of the wheel design, the size of it, its clearance under the bed, all sorts of things. A place to put coffee, which then the hospital said, no, you can't have the coffee on the things. But that's what the nurses wanted, but they took it off. And they now have a limited patent they filed, and they have made the pitch to Honor Health to actually invest in this, because they are so excited that this could make a difference in access, and the nurses feeling that two things, interestingly here, is that it's a better workplace on wheels, and even more importantly, the nurses feel heard. They feel that their needs were taken into consideration. So we're now working with this same facility to do more of these. So the students worked together, came up with this, built a prototype, did a pitch, and that was their summer internship. It was very cool. And the next one is, that's what we're going to do together. I think that the power of doing more, doing better, make it, is something that I am delighted to be part of, and I look forward to getting to know you and working with you. So thank you. And I'm happy to answer any questions if you have any questions or comments or whatever. My colleagues say that if you say, are there any questions, and no one answers, no one asks, you've done a lousy job. And in fact, when I do town halls, and I know for a fact there's also the chat going around during the Zoom that I'm not seeing, I can see I can see people typing. They say, if they don't ask you the question, you didn't do a good job.
Judy, can I ask you a question?
Yes, oh, thank you, thank you.
What do you see the pitfalls of AI? So if we flip that, and what are the pitfalls of AI for those people that aren't as digitally literate as the educators we have, and maybe ourselves? So what are those pitfalls we've got to be aware of?
Well, the bias, I think, is a big one. Privacy and bias, I think, are two big ones. And also the fact that we think that the answer, if it just sort of is logical, that it's right, which is exactly the same problem we have with evidence right now. So when somebody does a research and it proves what you think it should, you buy it. You don't question it. We should question that as well, by the way. We should be much more critical of, does that make sense? Things that we thought were true 10 years ago are not true today. So the same is the case with AI. It's going to give us answers, and we can't buy them hook, line, and sinker. Just like we shouldn't be buying the findings of a study hook, line, and sinker. We should be as critical of the consequences, but we should be as critical of consequences of all of these. If I do this, what's going to happen? So we should be always, what's the consequence of this? How much validity is here? So I think we need to be very good at assessing the information. But we also are not going to do it until we start using it. So on one hand, we don't want to use it until we get it right, but on the other hand, we're not going to understand how to use it until we start using it. So it's going to be checks and balances, and we need to feel comfortable enough with each other to say, that doesn't make sense to me. I don't buy that. It's not about you making a decision. It's about this. This is the way we improve. So I think there are pitfalls, but I think there are pitfalls in all the ways forward that we do things. We do things today that are just wrong, just plain wrong, and we've thought they were okay. I have been in nursing education for a really long time. And I'll just take something as simple as the way we treat pressure ulcers. The evolution of what is the right treatment for that over time is unbelievable, unbelievable. And the real thing is that we spent time looking at treatment as opposed to prevention. Why? I heard one of the founders of the checklist in the OR, Peter Provost, who invented the checklist for the OR, for how many sponges you have to take out. And he was at Johns Hopkins, and he was touting the fact that their infection rate post-surgery was only 2%. And it was like the best in the country. And he was at a seminar with undergraduate medical students, and a student raised her hand and said, "Why is 2% okay?" And he said, "It's not." And we accept far too much without challenging it. So I think we just have to continue to be critical and keep ongoing assessment of that. And we got to be sure that people aren't, blowing the privacy. But privacy in Australia and privacy in the United States is a lot different than privacy in, say, Latvia. So it is not a one size fits all. And when you talk about, so we did a study once. I was part of a study once that the culture that was doing it was wanting to put the blood glucose results on the dorm doors. When I was in college, we posted our grades by Social Security numbers. We would never do that today. So what is today's privacy rule and what tomorrow's? We have to be cognizant of the fact that there's not an absolute. It's a constant rethink. So thank you for not making me feel. Well, thank you all. I appreciate it. Oh yes.
One thing here, when you discuss about the design and thinking, so when it comes to the nursing curricula, human-centered design thinking, what's your view on this one when it comes to nursing curriculum?
I think it's fabulous, and in fact, that's that whole notion, and we try to use that in identifying what is the problem, not telling the students the problem, making them start with interviewing the constituents, understanding what their perception is. That's exactly how we did this WOW problem through a design thinking process. It requires the educator to move away from solution focused to, giving the solution and to changing the student to asking. And because we start our curriculum with this first course that tells the students your job is to come up with a solution as opposed to here's the answer, it has changed the way our students think. They have a belief that they have some authority, and it is expected for them to not just look for the answer. The reason that we're starting a new medical school at our university, our president says that most physicians, whether this is right or wrong, are trained, prepared to diagnose and use the most current evidence to come up with a solution, and come up with to treat it. This is the problem. I know how to do a good diagnosis, and I know how to access the most current literature. And our medical school is going to be engineering medicine, and he believes that the difference will be that the physician will be trained to be able to do the diagnosis and come up with a new solution, as opposed to an existing solution. We are trying to take that same philosophic approach to how we're preparing nurses. And so we're looking at in our world, a 4+1 baccalaureate program with an add-on master's in engineering, bioengineering. So our nurses stop calling them workarounds and start saying, I have an innovation. Yes.
Thank you for a wonderful speech. I'm from legal background, so I don't know anything about nursing and all sorts of health sciences. My question is relating to the importance of integrating cultural competence into nursing education. How important, how much importance does U.S. education give cultural competence within the nursing curriculum? And how do you see, its aspect of the value of educating our nursing students here in Australia when it comes to cultural competence, because that's a very big issue, given that it's a cosmopolitan, multinational, multicultural society, especially presence of Australian Aboriginal or First Nations people.
Yeah, I think it's really important. And I would love to say how fabulous we've done, and we haven't done so fabulous a job. I believe that until we have more people from each of those kinds of cultures as part of our profession, we will continue to do a lousy job. So I think it's very important for us to be able to take the education to the people. So if there's a person, we have a lot of tribal lands in Arizona, to take it to our tribal colleagues so the nurses can be prepared there, they'll teach us that. I also think the design thinking is another thing, that we need to start with we need to talk to people, not about, I've read the textbooks that show this is how you be culturally competent to somebody who is Jewish, and how to be, culturally competent to somebody from the Middle East. That's not how you do it. You got to talk to people. You've got to feel comfortable, and you have to know how rude you can be when you ask questions. So I think it's hard. I think it's hard, and I think it's something that we need to focus on all the time. We have had a spate in the United States of challenges around this in the last year. It's scary, quite frankly, from my perspective. Here we are trying to be more culturally competent, more responsive, and we get sort of shut down in some of our language. We just keep saying, this is important. We need to talk about this. And it's important, and I don't have an answer, but I believe I think it's important.
Thank you.
Yes.
Just a comment on that. So in my research in public health, so what we do is we do a co-design for the disciplinary action research approach. So we talk to people. For example, with the First Nations people, we talk to them and we involve them in all the stages of our research, right from the inception of a research study, and particularly in the research instrument design, and it actually works.
Right. Yeah, I'm aware of the research that's based in the community, and we have researchers that it's a little harder when you're the provider and you don't know how to ask the question, because you make an immediate something. So that's why it's exactly it's the same philosophic strategy, but we say this all the time in nursing. Well, it is life death. Well, it's really not life death all the time. You really do have time, for the most part, not all the time. I'm a psych nurse, so you have to say everything I say with a grain of salt. My colleagues, make fun of me that Judy is the one who says, "Well, let's talk about that," as opposed to "Let's do it." So, but I do think that sometimes we focus on doing something as opposed to listening, and we need to learn from our public health colleagues. Yes. Yeah.
I was going to ask, what you described seems to be a really interesting, fantastic way forward. I guess if you sit as a hospital administrator, something like that, I imagine in their minds going, geez, there's all sorts of risks that are popping up around us. How do we manage that? Just talk about how you see that working from perspective on this.
And of course, the worry about risk. So do you remember the time we couldn't take phones into hospitals? Because it was a risk. It was a risk. Now, it's not a horrible thing to have, some caution. And I think that, caution is good. But I also think that sometimes we I think you have to have good people around you so you can talk about this out loud without worrying. The hospital administrator has to be not afraid of listening to other people and not feeling like he or she has all the answers. One of our programs in my college is compliance and regulation. And we've been talking about, how does AI going to impact compliance and regulation? And there's a whole field of study now about, it's not attorneys for healthcare, it's somebody who understands compliance and regulation and the law. We need to, those people have to be better schooled. They, just like many areas, have been not connected to technology, and that needs to be a key part of technology. And we just had an advisory board meeting about that just the other day.
You've got to train the administrators in the same way.
We've got to train. They've got to understand they've got to understand technology just like the physician does and the nurse does. One of the other things that this MedTech accelerator that we have is really now trying to. We put one of our master's students in clinical research management as an intern with each of these startup companies. But now we've realized we should actually have an engineering student in the startup too. And so we just started doing that. And as you can imagine, they ask questions that no one would even like think of asking. So, yes.
So while nursing has been integrated with technology, that comes with a certain kind of risk. Even though you say that we are very like wearables and certain other technologies, these technologies, when they come up with a lot of information, these are utilized for personalized advertisement for
Sure.
several other companies. So in
Right.
terms of nursing, we have the critical information of the patients. So what do you think, where does that lie in terms of doing with normal digital variables for the consumers, and in terms of the critical information of patients, which could be at danger when it comes to technology, and that could be of use for various other companies in
Sure.
terms of selling those products as in terms of advertising as well.
Sure. No, it's a huge problem. Absolutely. The privacy thing is a big problem. So we have to come up with ways to do that. We have to have both guardrails in the technology, and we have to have public policy. We have to, what is the amount of personal information that's already out there? We already missed the boat in terms of our country about how much public access there is to anything you want about me. I mean, Alexa is collecting data every time I it's just scary how much there is. But I'm going to say this, and I don't want to be. I'm afraid it might be taken. Sometimes I think that worry is the fact that they have the information. It's not that they have it; it's what they're going to do with it, and that's what we have to have rules and policies about. What can they do with it? Because they're going to have it, and that's why we have to have strong policies with quick action in use of it. That's the part that worries me. Not so much that they have it, because I think a lot of it's already out there. Um, People have been sharing lots of misinformation for lots of years, but the volume of it is scary. It is scary how a company could use that data and really lie. Just lie, use it, screw you over, everything. So yeah, I think it's a concern, but it already is a concern. Yes.
I'm in the nursing education field. I have a question which inspired me about the automated grading system, which is a beautiful voice of the educator. But at the other side, the automated grading system can the student benefit the automated grading system, because I believe feedback is an individualized one. How the students can reflect on the automated grading system and help the student learning trajectory.
Yeah.
Can you please expand?
I agree. By the way, that I think feedback is the really fabulous thing. I can tell you that I'll just use an example of going over the test. This has been a controversy in my world. I have colleagues that will not go over the test with the student because he or she wants to keep the integrity of the questions. So, sorry. So even though they believe in it, they don't do it. I, on the other hand, go through every question, and how I do it is I put students in small groups. I say, here are these 5 questions, figure out what's the right answer and tell me why. So they give each other feedback. I don't give the feedback. So I think the same thing that can happen in automatic grading is first of all, the way you're testing, and then the way you're giving feedback. That you set up experiences that, okay, you students have to discuss the feedback or the answers to these 5 questions. You've already done the exam, but now you have to come up with it. So you build that in as a part of the class. The same way as people who are very worried about people using AI to write their papers. We have a lot of faculty who assign, you should go write a paper using AI on this, and then critique it. So they're told to do it, or they're told, identify the role of, you are a nurse and this is what you want, or you are the mother, and then compare the differences. So we're trying to use the power of the AI for the analysis. And the same is true with automatic grading. How do you build in, take these questions and let's go through them and get the feedback. I got to tell you though, some of the AI things with automatic feedback is amazing. So, and maybe a little clearer than I'm able to give in some of the answers. So I think we'll have to figure it out.
Thank you.
Yes.
Thank you very much for a wonderful section. My question is, it is more relevant to the previous discussion that you had. It's about evidence-based practice, what we're talking about. Do you, at the ASU, do you have any shortlisted, websites where who produce research? Because we know research, the outcomes depends on the one who funds the research. So do you have like the ones like usually we know there are accepted or peer-reviewed articles and journals that we can rely upon, but there are also certain companies or depends who funds the research. So
Right.
do you have any shortlisted and
Yeah.
tell your students not to use the errors?
Right. Yeah. No, I know. No, we don't. We have this discussion a lot. We have a lot of varied opinions in our faculty, and so we don't have like a blanket rule about that. We do teach a course on how for the student to do some of that kind of assessment. We do have a relationship at Elsevier that we're really looking at their portfolio and believing that it is a pretty integral and pretty the veracity of that's pretty good. I can remember when, this is sort of an aside, but relevant, when, what's the online encyclopedia, what's that called? Wikipedia. When Wikipedia first was invented and, it was like, oh, you can't use Wikipedia, it's a horrible thing. I got to tell you, we have fact that you should start with Wikipedia. Go to Wikipedia. It'll give you the background you need and then start investigating. My daughter is an academic librarian and she used to be the most like that Wikipedia, it is like the evil incarnate. She now says, did you start with Wikipedia? Because that will ground you in some of the questions. So even what was 20 years ago, the horrible thing is now something that we can use. Again, how do you use it? Not it's the answer, it's the starting place. And I feel the same way about some of the AI things, that it's a way to start with, I didn't think about that. What a good idea. Mm-hmm. Well, thank you. And thank you for indulging me with your questions. I appreciate it. Thank you.
Thank you.
I can work.